This continues the HIV/AIDS lecture. It's the second recording, and we're going to start with assessment, recognizing cues assessment for the HIV/AIDS content. So when getting a history for a patient who indeed has HIV or is being tested for HIV, you want to get a thorough history and provide a private location, provide privacy because of the stigma associated with the infection. You want to ask about current illnesses and their current health status, about any infections, and you're going to keep your ear open, listening for those opportunistic infections that you can now identify. You're going to ask about risky behaviors, unprotected sex, needle sharing, if they have a history of blood transfusions and they're a bit older, right? Nowadays it's a lot safer, but for your grandparents, that might have been a source of infection for them. Ask about any presence of STIs, any other infections, TB, hepatitis, any blood clotting issues, again in the past, before the screening on blood products became improved, it was possible to contract HIV through blood products. Ask about the sexual history of the patient. Do not assume a patient's sexual orientation, sexual behaviors, numbers of partners, or gender identity. Make sure to use gender-neutral terms, such as asking questions about their partner versus a boyfriend, girlfriend, husband, wife. Important to remain objective and non-judgmental and be supportive. And your textbook talks about focusing on the 5 P's: partners, practices, protection from STIs, past history, and prevention of pregnancy. For physical assessment, remember with stage 1, commonly the patient will just have some flu-like symptoms that then resolve, and they may be asymptomatic or only some minor symptoms as they progress to stage 2. But as the disease progresses, more severe health problems can occur. This is especially true for the patient who is not undergoing active treatment for HIV or a person who is an older adult. Always assess the patient for opportunistic infections, and we're going to look over some of those again here in a minute. The most common opportunistic infections that occur in stage 3 include candidiasis, cryptococcosis, cytomegalovirus, M. avium complex, P. eurovinci pneumonia, toxoplasmosis, and tuberculosis. And I'm pretty sure all those were listed in that box that you already looked at with the last recording. So what we're going to do now is look at the big table within the textbook that lists conditions found in stage 3 AIDS infection with assessment findings and nursing interventions, and we're going to highlight the ones that you need to be familiar with for testing purposes. Okay, for the cardiovascular system, going to be monitoring for coronary artery disease, heart failure, dysrhythmias. With the endocrine system, we'll be monitoring for hormonal changes such as low testosterone, menstrual irregularity, the presence of lipodystrophy or fat redistribution. It's more common with newer medications. GI, we're worried about anorexia, malabsorption, weight loss, diarrhea. We're worried about oral and esophageal lesions that occur with thrush or that fungal yeast infection of the mouth. Cryptosporidiosis is an infection that you want to recognize as an opportunistic infection, and what you need to know is that it results in diarrhea. That's something you're already familiar with. What are you worried about in your patient with diarrhea? 2 big things: fluid imbalance with dehydration and electrolyte imbalance. Under immune system, we got Candida albicans listed, which is the candidiasis. If the infection is in the oral cavity, the patient could have difficulty swallowing or mouth pain. With that treatment for that medications, a lot of times the patient will receive an antifungal. That's either a swish and spit or swish and swallow. The reason it'd be swallowed would be if the infection is traveling down the esophagus, right? They'll swish the medication around in their mouth to get everything covered, and then they'll swallow it so that it coats the esophagus on the way down. Important thing to remember, after taking a medication like that, the way it works is coming into contact with that infected mucous membrane. So we wouldn't want to chase it with water or anything to rinse it away. We want to let it swish it around, let it spend some time, make sure we get all the areas covered, and then let that sit and do its job. Other things listed here: cryptococcosis, which results in headache, neck stiffness, mental status changes, viral infections such as herpes or varicella zoster. Histoplasmosis is actually a fungal infection that's common in Ohio, so worth noting. Can lead to dyspnea, some general fever, headaches. We continue toxoplasmosis. If anyone in the class has ever been pregnant or had a partner who was pregnant, the pregnant woman's told not to change the kitty litter. That's because of the risk for contracting toxoplasmosis. Is acquired through contact with contaminated cat feces or ingesting of undercooked meat. Signs and symptoms include mental status change, headache, fever, neurological deficit, seizures, so a lot of neural issues with toxoplasmosis. Cancerous processes, HPV, anal, cervical cancers might be more common. Frequent one associated with AIDS is Kaposi sarcoma, which results in pink, red, purple, or brown papular lesions. Might have yellow halos. If they're intact and closed, not going to be that big of a problem for a patient, but they might be concerned with their appearance and want to hide those lesions. Other things under the neurological, you got HIV-associated dementia. Again, dementia is a condition that you're familiar with. This one's just caused by HIV infection. Sensory changes, gait changes, reduced sensory perception, neuropathies. You learned about neuropathies when you learned about diabetes, but now we're talking about them being caused by HIV. So what's a neuropathy? If you hear peripheral neuropathy, what's that mean for your patient? Hopefully you're thinking with those neuropathies, they're abnormal sensations. So tingling or numbness in the extremities, increased risk for injury. Renal issues include HIV-associated nephropathy. So pathies, disease, nephro would be kidney. Rapid deterioration of kidney function. Proteinuria, which would be protein in the urine. We normally don't see that, so that would be a diseased kidney if we're seeing protein in the urine. Under respiratory, got a couple here. You got Mycobacterium avium, pneumocystitis, Urology pneumonia, also known as PJP or PCP. That's a very common opportunistic infection that a patient with AIDS would develop. And then because that's such an unusual infection for someone who's immunocompetent, they would start looking at, if the patient's immunocompromised, and they could end up with a diagnosis that way. And the last one is TB, tuberculosis. Interesting, was almost eliminated from the United States prior to the early 80s with the AIDS epidemic. And once that we had an increased population that was immunocompromised, the amount of patients with TB increased as well. So that symptom chart, opportunistic infection chart, you're going to want to spend some time with, whether it's making notes or making flashcards, right? To get your head wrapped around those opportunistic infections, some of which may be new to you, and what you might see in the patient with those, and get those associated with your patient who might be in stage 3 AIDS. The psychosocial assessment I'm going to let you look at on your own. For all these conditions, I say to students, I think you could imagine how you would feel if you got the diagnosis that you're HIV positive, and sort of the struggles that you might have based on that diagnosis. So that one you can review on your own. We're going to hop over to lab assessment then. Lab assessment. HIV serologic and virologic tests detect infection. Serologic and virologic. So they're saying that they're looking at blood, and the virologic would be they'd be looking for virus. So there's really three ways that they look for an HIV infection. The first one is an antibody test. Does the patient have antibodies for the HIV virus? The second one is an antigen antibody test, where the antigen part of it also tests for the actual proteins from the virus. And the third one is a nucleic acid test, an NAT, that detects the actual virus. So these different types of tests can be done different ways. Blood tests are a common way. They even have home kits where a patient can do a finger stick to get a blood sample and then send it in. The big thing to know about testing, though, is that there can be false negatives. So if I let's say, had an encounter, whatever it may be, needle stick, a sexual assault, something where I thought I might have been exposed to HIV, and the next day I go out and get an HIV test. It's possible that that test would say negative, even though I was indeed infected with HIV, because my viral load isn't high enough to be detected. For that reason, patients are sometimes advised to come back for a second test if the first test is initially negative. And it looks like there's a 3-week window when HIV exposure and a test may produce a false negative result. Other things we can look at are the lymphocyte counts. So a normal white blood cell count is something, even though the NCLEX is going to give you that normal range, I would expect you to know, because a competent nurse will know that by heart. They don't need to look up a white blood cell count. So a normal white blood cell count is 5,000 to 10,000. And would you expect that to be high or low in a patient with AIDS? Hopefully you're guessing low. Patients with AIDS often have leukopenia, white blood cell count less than 4,000, and lymphopenia. What else can we look at? T cell counts. Do you remember how low a T cell count would be for an AIDS diagnosis? A T cell count of less than 200. If the patient's T cell count is less than 200, they're at high risk for the development of opportunistic infections. Viral load testing is another type of testing. Directly measures the actual amount of HIV viral RNA particles present in 1 ml of blood. So to simplify it, viral load testing determines the amount of virus in the patient's blood. It can be used to measure prognosis, disease progression, and effectiveness of therapy, and need for prophylactic therapy, and to determine survivability. So if a patient's on HIV medications, viral load testing is really important, because the goal of HIV medications is to keep the viral load down, right? And so the first thing we look at to see if a patient is compliant with their medications, if the dose of the medication is right for the compliant person, if the medication is working, we look at viral load, because the goal of HIV meds is to decrease viral load.